Now there's several theories as to why we see malignant nodules taller than wide. I can remember doing breast lectures about 10 years ago and saying, oh, it's the growth of tissue planes. Cancer grows against a tissue plane, benign lesions tend to grow with tissue planes. Some will say it's the lack of rotation within a fixed malignant nodule, or they may say that it's only because we're measuring the central nidus. It may be because of the incompressibility of malignant nodules. But the real reason of why we see cancers taller than wide, it reflects the axis of the orientation of a TDLU, terminal ductal lobular unit, in which a small cancer arose. Now you're saying, okay, Cindy, what did you just say? That's sort of confusing. I'll show you a diagram of what we're talking about. So if we look at the ductal system, and what we're going to do is take a cut right through this portion and now look at the short axis of that duct. If you notice, here is an anterior lobule. This is a TDLU. This is the extralobular terminal duct coming into the main ductal system. So if we're looking at anterior lobules, they have fairly long extraterminal ducts. If you look at posterior lobules, they have fairly short terminal ducts. So if we look at the pagetoid spread of cancer, where the yellow dot is where cancer will start. Cancer likes to take the path of least resistance. So as cancer starts to spread, you can see that if it arises in an anterior lobule, it's got a pretty good distance that it can grow before it hits the main ductal system and starts branching out and spreading. If you have a cancer that arises in a posterior lobule, there's a fairly short extralobular terminal duct. So when the cancer starts to invade or spread out, it's going to hit the main ductal fairly soon. If you have a cancer that arises in a terminal lobule, those cancers will never be taller than wide. They start out more in a transverse orientation to begin with. So here are examples of small cancers, all which arose in a TDLU. Here's a cancer that arose in a posterior lobule. You can see it looks like a tennis racket with a handle up. Here's a small cancer that arose in an anterior lobule, and here's one that arose in a terminal lobule. So these are all examples of small cancers that are taller than wide. If you notice, I keep saying small cancer. One reason is this is a feature that we tend to see in smaller nodules. We don't see it as often in large malignant nodules. If a cancer is less than 10 millimeters, we see this feature about 70% of the time. Once a cancer gets up to 2 centimeters, we probably only see it about 12 to 15% of the time. So it is something that tends to go along with smaller nodules. The entire nodule does not have to be taller than wide, but if any portion of the nodule is taller than wide, we will use that as one of the malignant findings. The next feature we're going to talk about is duct extension. This is when the cancer starts to grow back towards the nipple. So you can see this cancer here, and we've got a fairly long segment of duct extending down it. And this is very important as to why we want to make sure we scan in a radial plane. Radial scanning is scanning the same way like the spokes of a bicycle run. It's scanning in the ductal system. If you look in a fairly large breast center and you have never seen duct extension like this, it may be because you're imaging more in a transverse and longitudinal scan plane, but very important to make sure that you do see duct extension. If you've ever been into the operating room, one thing that you'll notice is when they go in and do a lumpectomy on a patient like this, what they'll do is make sure that when they remove the tissue that they have at least a 1 centimeter clear margin all the way around the lesion. Now, while the patient is still on the table, they'll send the specimen either for a radiograph or send it to pathology, and then they'll go ahead and start doing a sentinel node procedure while the patient's still on the table. If they send it to pathology and the pathologist is on the ball, what he'll do is say, you don't have a free margin, let the physician know what area, tell the surgeon. He'll go back in and take another cut of tissue. If the pathologist notices that it still has got a margin that is not clear, the surgeon goes back in and takes another sample of tissue, and a patient who went under the knife thinking they're going to have a lumpectomy has now had so much breast tissue removed that they need to convert it to a mastectomy. But what's even worse than that is if the physician or surgeon does the first initial cut and it's never detected that there was not a free margin, and say 5 years later this patient may re-present with, quotes, recurrent breast cancer. The majority of recurrent breast cancer is breast cancer that was missed the first time. Now, the next finding we're going to talk about is branch pattern. Branch pattern is just the opposite of duct extension. So instead of the cancer growing back towards the nipple, it branches out away from it. This is more of a soft finding. We tend to see this more with DCIS. But here you can see all these branches radiating out away from the nipple of cancer that has invaded, and the main lesion is sitting in this area here. Depending upon the nuclear grade of the cancer, if you have high nuclear grade, you may see large juicy branches. Medium branches tend to go along with your intermediate grade, and small branches tend to go along more with your low grade DCIS. Now, if you find an isolated duct extension or branch pattern, this indicates a benign intraductal papilloma about 87% of the time. But 6% of the time are DCIS, and another 7% can be atypical ductal hyperplasia. So you cannot classify this as being a BI-RADS 3. We want to make sure that we're 98% sure that it's going to be to call something a BI-RADS 3. So having an isolated finding of duct extension or branch pattern tends to be benign majority of the time, but still it's not enough to call it a BI-RADS 3. These should be given at least a BI-RADS 4A and should be biopsied. The next finding we're going to talk about is acoustic shadowing. This is a hard finding. When we see acoustic shadowing, typically we're dealing with an invasive carcinoma. Now, depending upon the degree of desmoplasia is how much shadowing we will see behind a lesion. We may have a breast cancer that shadows entirely behind it, or we may have a lesion that only has partial shadowing behind it, and it just, once again, depends upon the desmoplastic reaction that we'll see posterior to that lesion. If we look at the histology grade versus sound transmission, your low-grade ductal cancers, invasive ductal carcinomas, tend to have shadowing seen behind it. High-grade invasive ductal cancers tend to have enhanced through transmission seen behind them. We did a study looking at 409 solid malignant nodules, and we could see acoustic shadowing, either partial or complete, 35% of the time, normal sound transmission behind the lesion 32% of the time, and enhanced through transmission about 28% of the time, and mixed findings 5% of the time. So if you're looking for the presence of shadowing to call something a cancer, you'll only be right about a third of the time. Cancer can present itself in any way that it wants, either with normal sound transmission, enhanced sound transmission, or shadowing. Dr. Stavros always called our high-grade lesions poor man's color Doppler, said that if you did not have color, you could just imagine the flow, but the cancers that have the enhanced through transmission behind them are the ones that are going to light up with color Doppler, so we will see quite a bit of flow. One other thing to note is anytime you're looking for the presence of blood flow in a lesion, you want to make sure that you scan with very light pressure. Scanning with light pressure is when we will see flow. If you're scanning with heavy pressure, you can temporarily ablate all the flow. So anytime you're looking for the presence of blood flow, make sure you scan with very light pressure. Now, if we look at acoustic shadowing and enhanced through transmission differential diagnosis that we'll see with those, with our low-grade shadowing, we're going to see low-grade invasive ductal cancer. Invasive lobular carcinomas also cause shadowing, and tubular carcinomas once they're over 1.5 centimeters in size. Enhanced through transmission we'll see with our high-grade invasive ductal cancers, colloid carcinomas once they're over 1.5 centimeters, medullary and invasive papillary also have enhanced through transmission. The next finding we're going to talk about are calcifications. That tends to be more of a soft finding, which we'll see with DCIS. If you notice, we can see these tiny little calcifications inside the solid nodule. Now, a lot of times the calcifications that we see mammographically are within a duct. You're saying, your doctor may say to you, I want you to go ahead and scan this patient, and you're going, but there's only calcifications. Ultrasound is not real good at picking up calcifications, but what your doctor wants to do is see if there is any mass associated with those calcifications. If there's a mass associated with the calcifications, it's going to be much easier to biopsy those with ultrasound guidance than it is stereotactic method. But typically the calcifications seen inside the duct we do not see with ultrasound. The duct is echogenic, the calcifications are echogenic. We typically will only see ones when they are associated with a mass. The next malignant finding we're going to talk about is markedly hypoechoic. Now, we used to be, in the old days, we would see cancers that look just like this. This is markedly hypoechoic compared to the surrounding fat. Nowadays, we don't tend to see cancers that are those dark. And one reason is we're running with equipment that's so much better than we had in the old days. Here's some more examples. This is a cancer that is markedly hypoechoic compared to the fat, and one with intense shadowing that we can see is also markedly hypoechoic compared to fat. Now looking, why is it we don't see this feature as often as we used to? I'm going to show you the same lesion scan the same day. The only difference is I changed the dynamic range. Here we have a dynamic range of 68 dB, and then what I'm going to do is actually increase my dynamic range to 90 dB. Notice here where we have a lesion that is markedly hypoechoic compared to the fat. Now this lesion is almost isoechoic compared to fat, and the only thing I changed was dynamic range. Our machines that we're using nowadays run with much wider dynamic range. We have broadband technology, compound imaging, things like this that help improve our image, that we're just not seeing cancer as dark as we did before. Also, if you notice, we can see this area of central necrosis much better in the lesion running at 90 dB compared to the one at 69 dB. I'm not saying that we need to all drop our dynamic range way back and start scanning so that we've got more contrast in the image, but just beware that we typically see lesions a lot more isoechoic currently than we used to. You may say, Cindy, what happens if I have a really bad day and I happen to miss one of those malignant findings? The average breast cancer has 5.3 malignant features to it, so even if you're having a bad day, hopefully you'll be able to pick up at least one of those findings. So once you've searched that solid lesion, you've looked for all those different malignant findings, you've not found any of them, now what we have to do is prove that the lesion is benign. What we have to do is find one of the three to be able to classify it as a BI-RADS 3. Either markedly hyperechoic tissue, we want to see an elliptical shape, and we will allow up to 2 to 3 gentle lobulations. Now we need to make sure that that lesion is completely surrounded by a thin echogenic pseudocapsule. So we'll talk about these. Purely hyperechoic, we can have a ridge of normal fibroglandular tissue or an area of just sort of fibrosis or normal tissue. This showed up as a mammographic nodule, so we knew it wasn't a lipoma. Sometimes lipomas can appear to be echogenic like this in the subcutaneous fat, but since it showed up on the mammogram, this is just an area of fibrosis. This is something we would consider purely hyperechoic and nothing else needs to be done. Now looking at this lesion here, this is not purely hyperechoic. There is a small lesion in the center of it that is isoechoic, so we would not classify that as being purely hyperechoic tissue.